let's go to the post-neoadjuvant setting. So, Rashmi, so what do you think, Rashmi? Do you think everybody get TDM1 post-neoadjuvantly right now at MD Anderson who has residual disease after TCHP or whatever you give them?
Yeah, so anybody with residual disease, we offer TDM1 to. I think one of the striking data from the KATHERINE study that actually kind of hit home for me is, the impact of TDM1 versus Herceptin on the patients who develop CNS metastasis. There really wasn't a huge difference. I think there was about 5% in both arms who still ended up with CNS relapse. And so, I think, thinking about the role for drugs such as neratinib, a HER2 tyrosine kinase inhibitor in the extended adjuvant setting, after TDM1, even though we don't have data for that, we don't have data for the role of neratinib, pertuzumab, or TDM1. I think given that patient population that's really not receiving much benefit or impact from TDM1, I think there should be some thought for use of neratinib. And I certainly discuss it with my patients who are extremely motivated, who are younger, and who have very high risk residual. If they have a large amount of residual disease after neoadjuvant therapy, I do talk about both TDM1 as well as extended therapy with neratinib.
Before we get into kind of the lower limit of what people would treat with here, let me ask you a question. Are you involved in COMPASS now? Because I know you were involved in HER2 Climb. Are you involved in COMPASS at all?
Yeah, I am involved in COMPASS. So that's another trial that's coming up that patients will be able to enroll onto. It's currently going through the regulatory process.
Can you explain that design to our viewers just so they know? Because it's a really cool trial that's going to be very important.
Yeah, so this is a randomized study that is looking at patients with disease after neoadjuvant treatment with a taxane plus dual HER2 targeting with trastuzumab and pertuzumab. And so it randomizes patients in the postoperative setting to receive either TDM1 or TDM1 plus tucatinib. And so the thought is to further escalate adjuvant therapy for those with residual disease.
So that's cool. So so we're going to have these HER2 tyrosine kinase, because remember, it was a 12% relapse rate despite the TDM1, right? 11, 12%, and half of that was brain mets. And so the brain mets, as you pointed out with, are going to become the most important thing that we're going to deal. I mean, obviously resistance is important, but, clearly we have a wide open field to be able to treat that 5 or 6% of people who develop brain mets, as their first site of relapse. So let me ask Carrie, what's the minimum amount of disease you would treat in the post-neoadjuvant with this therapy?
I remember right after KATHERINE was presented, I got an email from a colleague, had just gone home after I think it was San Antonio conference, and said, I had a patient who just came in after her TCHP. She has 8 millimeters residual disease, lymph node negative. Would you give TDM1? And so I went back to the New England paper, and if you look at the forest plots, pretty much every stage of residual disease benefited from the TDM1 over trastuzumab. So I actually really haven't had a lower limit cutoff. I'd be curious to hear if others have taken a different approach, but I've routinely recommended TDM1, and I'm happy to have the COMPASS study on the horizon with the addition of the tyrosine kinase inhibitor to see if that might help as well. The other thing I think is perplexing, and I see this a lot in my practice taking care of patients with brain metastasis, is I also see patients with pathologic complete response recur in the brain as the only site of disease. So I just think it's something for us to think about for our patients who have a path CR. It'd be nice to have some predictor, even in those patients that we kind of relax our shoulders about, to know if they're at higher risk for CNS recurrence. So I think as much as we congratulate the path CR, I am struck by the number of women I see in my CNS metastasis clinic who had a path CR to HER2-directed therapy. So I just want us to think about that further.
Yeah, no, I agree. I mean, guys, do you think like the prevention of brain mets, Mark, you think the prevention of brain mets in the setting is going to be in advance if we can do it?
That'd be huge, and there's no doubt about it. And I do like the idea of integrating tucatinib into the extended adjuvant setting, because it's, as a single agent, and certainly in combination with endocrine therapy, it would be very manageable in terms of safety signals. So in addition to combining it with TDM1, one wonders, could you do it following TDM1 and with perhaps even as a primary endpoint, of onset to brain metastasis. I think that would be a very clever strategy moving forward.
The problem is that we're going to have to basically, the power of this is going to be huge. I'm assuming what is COMPASS going to be a couple thousand patients. I mean, you know, we're getting to the point now where we're above 90%, you know, and to get each little increment above that is going to take, you know, thousands of people, kind of like the cardiologists. And I don't know what we're going to do. I don't know if we're going to find all these people. It's going to be really tough.